Good afternoon, and welcome to the Lewy Body Dementia Association's LBD University program. I'm Angela Taylor, LBDA's Director of Programs, and I'll be your host and moderator for today's webinar. This year, we're pleased to offer a series of 3 Ask the Expert webinars, and today's expert is Dr. Brad Beauvais. He's a member of our Scientific Advisory Council, and he'll be presenting Comprehensive LBD Clinical Care. Dr. Beauvais is the chair of the Enterprise Subspecialty of Behavioral Neurology of Mayo Clinic, chair of the Division of Behavioral Neurology at Mayo Clinic Rochester, and is professor of neurology in the Mayo Clinic College of Medicine. He's a diplomat of the American Board of Psychiatry and Neurology in Neurology and Sleep Medicine, and the United Council of Neurologic Subspecialties, Behavioral Neurology and Neuropsychiatry. Dr. Beauvais' clinical and research interests include mild cognitive impairment, dementia with Lewy bodies, and Parkinson's disease with dementia, and REM sleep behavior disorder, among many others. He's authored about 30 book chapters and has contributed to over 400 papers in peer-reviewed journals. So we really welcome Dr. Beauvais to be with us today. Today's webinar will begin with his presentation, which is being tailored to the healthcare professional. There will be a question and answer period following his presentation. So to submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit those questions throughout the presentation, and following it, I will present your questions to Dr. Beauvais, and we'll address as many as we can within the time allotted. Our webinar is being recorded today and will be available for on-demand viewing in just a day or two. And in addition, the handout tab of your control panel contains today's slides, which you can download and review at a later time. So now I'm pleased to turn things over to our guest, Dr. Beauvais.
Great. Thank you, Angela. Hello to everyone. Thanks to everyone for participating today. And let me just gear things up here. So again, it's my honor to participate in today's webinar. Thanks again to everyone for your involvement. The topic is the comprehensive approach to DLB management. First, a few disclosures. I do have some relationships with the National Institutes of Health, the Mangurian Foundation. We do have some funding from industry for some clinical trials. I don't receive any personal compensation from any industry partners. More importantly, as most, if not all, are aware, there are no FDA-approved medications for DLB and DLB-related symptoms. We will be covering a number of medication as well as non-medication options, and if there's time, we may talk about some devices or scans as well. So let's start with a question. So if each of you could answer this through a poll, which of the following statements is true? 1, all of the symptoms in DLB reflect problems in the brain. Number 2, almost all of the symptoms of DLB primarily reflect problems related to the chemical known as dopamine. 3, the degrees of neuronal death and brain atrophy are greater in DLB compared to Alzheimer's disease. 4, the primary way to manage the problematic symptoms in DLB is to use medications. And number 5, the diagnosis of DLB is not easy and the management of DLB is highly complex. If you could just mark 1 through 5, which is most likely to be true in your minds. And this will take several seconds while everyone responds, and then Angela will kindly review the responses.
Angela, if you can Unmute your line.
Thank you. I'm so sorry, everybody. Okay, 37% of our participants said that all DLB symptoms reflect problems in the brain. 20% say all DLB symptoms primarily reflect problems with dopamine. 31% suggested that neuronal death and brain atrophy are greater in DLB than Alzheimer's. 11% said the top way to manage problematic symptoms in DLB is to use medications. And 96% said that the diagnosis of DLB is not easy. Management of DLB is highly complex.
Great. And the correct answer is number 5. This is a challenging diagnosis for most clinicians, and management is about as challenging as any neurologic entity is. And we'll address items 1 through 4 over the slides that follow. So dementia with Lewy bodies, the term Lewy bodies, the Lewy body was first described by Dr. Frederick Lewy, or Lewy. He was a German neuropathologist, and his name was attached by others. A view of a Lewy body as it looks like underneath the microscope is on the left in this slide. You see this round brownish structure here. And what a Lewy body represents is a conglomeration of misfolded alpha-synuclein protein. And so the driving force, most scientists and clinicians believe it's the misfolded protein alpha-synuclein. It's in Lewy bodies. It's also in what's called Lewy neurites, which are structures in the axons and the dendrites of nerve cells. And while Lewy bodies and Lewy neurites are clearly in the brain, as is shown in this schematic right here, the neocortex, which is the main thinking part of the brain, other structures in the brain, this pathology, Lewy bodies, Lewy neurites, is also in the brain stem, as reflected here, in the spinal cord. And very importantly, for some of the symptoms, it is in some people in the retina, which is part of the structure of the eye, in and around the heart, in and around the intestines, the bladder, and the sex organs. So many of the symptoms in DLB does reflect changes in the brain, but many other symptoms reflect problems outside the brain. So unlike structures such as Alzheimer's disease and some of the other disorders that affect cognition, Lewy body disease affects nerve cell structures in the brain and elsewhere, making this, again, one of the more complex neurologic disorders that we see. Another way to view the symptomatology in DLB is shown as on this Venn diagram. And we like to group the manifestations in the cognitive realm. So these are thinking-related symptoms, the neuropsychiatric realm. So this includes delusions, hallucinations, depression, motor, primarily reflecting Parkinsonism. There are many sleep disorders. We'll talk about these a little bit later. The autonomic manifestations and the sensory manifestations. And what's meant by this Venn diagram is a person might fall in this area, for example, here, where there are cognitive, sleep, autonomic, and sensory issues, but at this point in time, there's no Parkinsonism and no neuropsychiatric features. Over time, then symptoms can evolve, and a lot of people then may begin more in the periphery of this Venn diagram and evolve more and more towards the middle. So this depicts the very variable manifestations of DLB in individual patients, and also it's a snapshot in time, and over time the symptoms evolve just with progression of the illness. And that progression, not only the time course, but also what symptoms develop in the future, are very difficult to predict. So a useful technique that many clinicians worldwide now use is to put the question to the patient and the family, can you please prioritize what symptoms are most bothersome from your perspectives? This then helps the clinician decide how best to approach optimizing management. And you'll hear this theme over and over again, but what are the cognitive issues, neuropsychiatric, motor, sleep, and autonomic issues? And within them, please prioritize which is priority number 1, number 2, and number 3. And stopping at 3 is worthwhile because we then focus on priority number 1. Sometimes, and in some cases often, we can improve priority number 1, and number 2 will move up to number 1, number 3 will move up to 2. So again, it helps with the management approach on how to attack the target symptoms. Now, the second question, if you can also respond to this question, this one might be a little bit easier. Which of the following is least likely to be beneficial for individuals with DLB? 1, the cholinesterase inhibitors. This class includes Aricept, Exelon, and Razidine. The traditional neuroleptics, one example is Haldol. Number 3, education and counseling. Number 4, exercise. Number 5, melatonin. So which among those 5 choices is least likely to be beneficial? And again, we'll wait a little bit while everybody responds.
Okay, and we have our results. 9% say it's the cholinesterase inhibitors. 78% say the traditional neuroleptics. 4% say educational and counseling. Nobody thought exercise would be the least beneficial, and 9% thought melatonin would be the least beneficial.
Great. So this is a savvy group. It is true the traditional neuroleptics we try to shy away from, and we'll emphasize that point in a minute. So as we go forth with a planned approach, I'll start with this template slide. So what I'm going to be showing is some of the structures in the neurochemical systems in the brain. It's helpful to know what neurochemical systems are involved in DLB and what chemicals relate to which symptoms. And so this is a good place to start. So this is supposed to look at the brain from the left side, front of the brain over here, back of the brain here, and then this slice A represents slicing the brain like this, and then turning the brain so we're looking at the person head on. This is slice B, and this is slice C, more towards the back of the brain. And this logic will be more apparent as we proceed. So the main neurochemical systems, these are not the only ones, but the main chemical systems that are dysfunctional in DLB include acetylcholine. In medicine, this is often abbreviated ACH. There is controversy over this, but some data supports hypocretin, which is in the lateral hypothalamus, is dysfunctional. Dopamine, which is more in the substantia nigra in the base of the brain. 5-HT is the abbreviation for serotonin, which is from the raphe nucleus, a fairly large nucleus in the brainstem. Glutamate, glycine, and other chemicals are involved with some of the sleep circuits. And I don't have it depicted here, but norepinephrine, which is from the locus ceruleus, which is right about this small spot right here. And really, to summarize, every neurochemical system that has been studied in DLB has been found to be dysfunctional. And a very important point to emphasize is in Alzheimer's disease, some of the same chemicals, not all of them, but some of the same chemicals are affected in Alzheimer's disease. The challenge in Alzheimer's disease is there's much more neuronal cell death, And if the nerve cells die, then any use of medications, they're less likely to provide a benefit because the cells aren't there to benefit from that manipulation. In contrast, in DLB, the cells are living for the most part. They may not be working correctly or in sync, but they're alive. And so this is part of the philosophy of using medications. As long as we're careful about this, and some patients really do benefit from one or more of the medications we're going to talk about. So let's talk about the cognitive issues. For most people, this is one of the more bothersome symptom complexes. Cognition, it largely relates to a depletion of the chemical acetylcholine. Hypocretin, dopamine, serotonin, those depletions also contribute to cognitive symptoms, although not as much as acetylcholine. And again, there's some degree of nerve cell loss. But these neurochemical changes really affects almost the entire brain, and that's why so many cognitive symptoms evolve. So this is a summary of some of the cognitive symptoms, varying degrees of memory impairment, verbal blocking, and that term refers to a person starting a sentence and then stopping mid-sentence as if losing the train of thought. Executive dysfunction refers to problem solving, complex decision making, multitasking, and the like. Bradyphrenia is a neurologic term meaning slowness of thought. Spatial and geographic disorientation refers to, as one example, having a hard time navigating in one's own home, so trying to find the bathroom, and if symptoms are milder, getting lost while driving or trying to find something in a store and not being able to locate that item. Visual misidentification refers to, as an example, a pile of towels on the floor in the bathroom and the brain interpreting that as a cat or a dog. So some stimulus kind of tricking the brain into thinking that it's something else, like an animal. And then fluctuations. This is a very poorly understood aspect of DLB. This refers to fluctuations in cognition and or arousal. And we hear quite often that some hours or days are a lot better than other hours or days. How do we approach these cognitive issues? First, education and counseling, just understanding what's at the root of these symptoms. There are a number of non-medication approaches, and this can be through cognitive rehabilitation or occupational therapy and procedures. If medications are to be used, by far the group that's used most frequently, and most, not all, but most people do have at least some benefit, are the cholinesterase inhibitors. So these are medicines like Aricept, Razidine, and Exelon. The generic Aricept, the generic is donepezil. Razidine, the generic is galantamine. And Exelon, the ribostigmine. And Exelon's the one that comes in a patch. So Aricept, Razidine, and Exelon. Namenda is another medicine that, in all honesty, has a modest effect. It works through the chemical glutamate. Sometimes the medicines that work on dopamine, for example, Sinemet or carbidopa-levodopa, Mirapex, Nupro, there's several medicines in that class. We use those more for the Parkinsonism aspects, but they can have a bit of an effect on cognition. The medicines that are known as psychostimulants or wake-promoting medicines, Provigil, Nuvigil, methylphenidate, Adderall, there's several in those classes. Those are controversial, but they can impact cognition too. So these are all options therapeutically when non-medication approaches just aren't providing a maximal benefit. If we turn to the neuropsychiatric issues, these are more depression, apathy, hallucinations, delusions. Many of these symptoms relate to a dopamine imbalance. to some extent acetylcholine, to some extent serotonin, some of the other chemicals, and the specific manifestations in this neuropsychiatric class include visual hallucinations, illusions, delusions. Capgras syndrome refers to the belief that someone looks like an individual but is an identically appearing imposter. It's not very common in DLB, but it can be really upsetting to especially a spouse when you look like my wife, but you're not my wife. That's what is often stated. Depression is extremely common in DLB. Anxiety is pretty common as well, and in some instances, agitation and aggressive behavior. The main issue in the symptom complex, visual hallucinations can be quite problematic, and when there's hallucinations, a lot of times delusions form around those. Importantly, though, is when hallucinations or delusions or both are present, a knee-jerk reaction is to use a medicine, but in a lot of instances, a medicine is not needed. So, for example, if a person looks outside and sees someone or something outside in the yard, if it's not frightening and it's not consuming a lot of that person's thought, then redirection, talking about some other topics of interest, we don't want to jump to a medication if it's not critical. However, if hallucinations are problematic, if they're frightening, if they're leading to a lot of dismay or fright on the part of the person, or if delusions are developing, then there is a role for medications. And as you can see in the red animation, Haldol, other medicines in that particular class, Thorazine, Mellaril, Stelazine, but Haldol is the most common agent in that class. And unfortunately, Haldol is still used with some frequency in people with DLB. A general rule is to avoid that medicine. There are other options that are far better, far safer. So an important point. What therapies to use if any of these symptoms are problematic? Again, the cholinesterase inhibitors, they were designed more for cognitive purposes, but they can help in some instances dramatically for hallucinations and delusions. These, again, Aricept, Razidine, Exelon. Depression, the selective serotonin reuptake inhibitors. These are the antidepressant medications, so SSRIs, a similar class, the SNRIs. Seroquel, Zyprexa, there are many of what are called the atypical neuroleptics. This class is controversial. They are associated with a black box warning, but when symptoms are very troubling and non-medication options or even these other classes of medicines aren't working, they are considered. Provigil, Nuvigil, methylphenidate, Adderall, they can help to some extent for hallucinations. Sometimes they also help for apathy. The point here is almost all medicines directed towards the neuropsychiatric features, they have some negative qualities associated with them, so they have to be chosen carefully, and we'll come back to this point in a few minutes. Motor issues, this primarily relates to Parkinson's-related symptoms. These primarily relate to dopamine depletion, so a low dopamine level in the brain. And the specific symptoms or features include tremor, bradykinesia, that refers to slowness of movement. Rigidity is stiffness in the arms and legs or neck. Myoclonus is rapid movements or jerks of the arms or legs. Shuffling gait, stooped posture, difficulty with, for example, buttoning buttons, using a pencil, using a zipper. Masked faces, so the loss of facial animation, and Rhinorrhea, which is the medical term for drooling. all of these relate to dopamine depletion, and there are a number of non-medication approaches. Again, knowing what these symptoms relate to. There are several studies now in Parkinson's disease literature that physical therapy, to some extent occupational therapy, and gentle exercise is beneficial. Some people have dancing as a therapy. A critical point is, as long as balance is okay, gentle exercise, physical therapy, and the like can be beneficial. And for those who have the resources to get a personal trainer or to work with one or a group of people at YMCA, for example, those can be very beneficial. If medications are used, Sinemet or carbidopa-levodopa, which is a generic for Sinemet, that's the mainstay of treatment. And that medicine, as well as Mirapex, Requip, the Nupro patch, each of these acts on the dopamine system to boost dopamine and can improve a lot of these motor symptoms. And then depending on other things like myoclonus, clonazepam or Neurontin sometimes used, but myoclonus is relatively uncommon. So if any group of medicines are used for the Parkinsonism, they primarily act on dopamine. Moving on to sleep issues. We have been pursuing sleep issues for literally a couple decades now, and we have yet to meet a single person who doesn't have one or more sleep disorders that's undiagnosed and untreated. So in other words, sleep issues in DLB is rampant and often missed. These types of symptoms relate to sleepiness, insomnia, acting out dreams, which is very common in DLB. That particular disorder is known as REM sleep behavior disorder. Interestingly, RBD, as it's abbreviated, often will present years or even decades prior to the onset of cognitive or other motor features, often with nightmares of being chased or attacked by something or someone, and that normal paralysis that all of us have in REM sleep is lost, and therefore a person literally seems to act out dreams. And injuries can happen to the individual or to their bed partner. They can fall out of bed. Again, very common in DLB. And many of these sleep issues relate to either dopamine dysfunction, serotonin dysfunction, glutamate or glycine dysfunction in the brainstem. The sleep issues are quite complicated, but again, very common in DLB. In addition to RBD, which I just mentioned, daytime hypersomnia, so excessive daytime sleepiness, insomnia, obstructive sleep apnea is quite common. Central sleep apnea, which is kind of a cousin to obstructive sleep apnea, is, I would say common, but it's present in a minority. Restless leg syndrome is pretty common, and periodic limb movements during sleep, which is when the legs periodically jerk while a person is sleeping. And there's a number of therapies for these sleep-related issues. If, for example, REM sleep behavior disorder is a problem, the first course is just improving safety in the bedroom. So move sharp objects away from the bed, such as a nightstand. Have a thin mattress placed next to the bed, so if a person falls out of bed, it's a softer landing. So some simple safety-related issues. If RBD is severe enough that you still need to treat it, melatonin is the first-line therapy, 3 to 6 milligrams per night. If that doesn't work well, then clonazepam is used. Now, clonazepam is controversial in anyone who's older or has any cognitive symptoms, but many people do benefit from clonazepam at a low dose. But again, it is a controversial medicine in this setting. Provigil and Nuvigil, methylphenidate, Adderall, all can improve daytime alertness. If insomnia is problematic, trazodone, Ambien, chlorohydrate, again, we don't like using these medicines at night in the setting of cognitive issue, but they can be used as long as it's used carefully. A common thing we hear is in someone who has a dementia syndrome, there's no chance they will tolerate nasal CPAP therapy. That's wrong. Many people tolerate CPAP therapy and they benefit from it. So if a person has obstructive sleep apnea, it's definitely worth using it. Not everybody's going to tolerate it, but it's not right to assume that they won't. And I've seen personally many folks who tolerate CPAP and they clearly benefit from it. Oxygen therapy, temazepam, some other forms of therapy. And then if restless leg syndrome and or periodic limb movements occur during sleep, medicines like Sinemet or Mirapex or the Nupro patch. So these sleep issues are important, and a lot of clinicians now, when they first meet somebody with DLB, first try to understand, is the diagnosis correct, or establish a diagnosis. They consider the cholinesterase inhibitors if it's not already being used, but they really focus early on, we need to make sleep as optimal as possible. It doesn't matter what medicine and non-medicine approach you use, unless or until a person has better sleep at night, you don't expect to see much improvement during the day. And I think that's a very solid rule of thumb. And then finally, the autonomic issues. These are things like rhinorrhea. That's the medical term meaning runny nose. This is actually pretty common in DLB. It's also pretty common in Parkinson's disease. And we hear often also that people can have what's called gustatory rhinorrhea. That means that the runny nose especially comes when a person's eating. Orthostatic hypotension is extremely common in DLB. This refers to the drop in blood pressure when a person is standing or walking. In some people, this is pervasive. It can lead to falls, broken bones, lightheadedness, passing out, and there are strategies to treat this. Impotence is pretty common. Urinary incontinence, fairly common. Constipation is quite common. And the way to manage these, depending on the symptom complex. So, for example, rhinorrhea, if it's minor, then we don't treat it. If it is really bothersome and socially embarrassing, that runny nose is compromising being around people or going out to eat or things like that, Flonase or other steroid nasal sprays, they don't work all that well, quite frankly, but they're pretty safe and could be used. Another one known as Atrovent is sometimes used right before you're planning to eat, if it's especially a gustatory rhinorrhea. Some people do have a cognitive side effect with Atrovent nasal spray, but usually it's tolerated perfectly fine. If a person has orthostatic hypotension, we usually go the non-medication routes first. So this is one of the few times that we add salt to the diet. Gatorade or other salt-containing beverages, salt tablets. Elevate the head of the bed 30 degrees. There's some logic to stressing the autonomic system during sleep, and that's one way to do it. If those measures don't work, as well as thigh-high stockings or abdominal binders, other types of techniques to try to maintain blood pressure in the face of gravity when standing, then medicines like mitadrine, Florinef, or both of them. For impotence, Viagra, Cialis, obviously this is more in males. And then urinary incontinence, this is hard to treat. There are medicines such as Enablex, Gelneek, Sanctura. Some of these are pretty expensive. Medicines like Detrol or oxybutynin, they do affect acetylcholine in the brain, and we don't want to decrease acetylcholine in the brain. So this is an example where finding that balance of trying to manage the urinary problems and not making the cognitive symptoms worse. Enalix, Gelneek, Centura have far less impact of brain acetylcholine, and that's why I have those listed here. And then constipation is pretty common. Sometimes the cholinesterase inhibitors, because they can cause loose stools, it actually helps cognition and helps constipation, so we can use the side effect of the medicine to try to combat a problem like constipation. But most people find that adding fiber to the diet, drinking more liquids, Senecot, Miralax is the most commonly used agent. This is over the counter. It increases water content to the food that you eat and can help with constipation. Now, this is a very busy slide, but this is really the challenge in managing symptoms in DLB. The clinician, the patient, the family all have to consider the pros and the cons of any medication if a medication is going to be used. This is not meant to scare off the utility of certain medicines, but we have to think this through with each medicine. And just to look at a couple of examples how to read this complex slide. So let's look at the acetylcholinesterase inhibitors, or the cholinergic medicines. The green represents more positive effects and the red more negative effects. So this class of medicines often improves cognitive symptoms, often improves hallucinations and delusions, to some extent apathy. Sometimes they'll worsen Parkinsonism. That's pretty rare, but it can happen. It'll often improve daytime alertness. Usually this class doesn't do much for things like REM sleep behavior disorder, and they can help with orthostatic hypotension. And as you can see, there's far more potential pros than cons, and that's why the cholinesterase inhibitors are used so frequently in DLB. Contrast this with, for example, the atypical neuroleptics or the dopaminergics. The atypical neuroleptics, they can worsen cognition. We use them primarily to decrease hallucinations and delusions, but they can make people more sleepy. They can worsen orthostatic hypotension. Erectile dysfunction can get worse. The dopamine medicines, they usually help the Parkinsonism, but they can make hallucinations and delusions worse, and they can make orthostatic hypotension worse. So this is really the challenge of management in this setting. So if medicines are used, one medicine at a time, start slow, gradually adjust it, level off, see the benefit or lack of benefit. The fortunate thing is if side effects do happen, they're reversible, and so you back down on the dose or you stop the medicine completely and you change course. So there's rarely any permanence to any downsides to these medicines. But it can be quite frustrating when you employ a medicine, you don't see a benefit after days or weeks, change course, use a different therapy, same thing happens, and this can go on for weeks or even months. However, it's worth the effort. Use every non-medication approach that we have available, and careful use of medicines, and it's worth the effort. And then this slide is just to depict there are some clinical, laboratory, and electrocardiographic effects, and most clinicians are aware of this. So most of the medicines, you don't have to worry about lab checking blood tests if we're using any of the medicines. There's one in the atypical neuroleptic class that you have to do that. But some of the medicines can affect the heart rhythm, and we have to be careful. Sometimes we'll do an electrocardiogram before we start one of these classes of medicines, and there are some clinical effects. So again, the potential downsides of the medications. Resources, obviously, most, if not all of you participating in today's webinar are very familiar with the Lewy Body Dementia Association. It's the resource, and many of the things that we've been covering today are on the web page that I have shown here on this slide. And up until about a year ago, there were no national active clinical trials in DLB, and this has been a huge problem from an experimental basis, the absence of any clinical trials. There are several now going on in North America, several in Europe as well. You can find out a clinical trial near you by going to this website listed here and by filling out just a couple things and putting in your zip code. You'll see what studies may be close to where you live. So it's an easy website to search for clinical trials. Now let me turn a little bit to where the future is going. And this slide is meant to show that in someone who's destined to develop DLB, often they'll start having features of REM sleep behavior disorder even decades before the DLB symptoms. At some point, there will be a change in their cognitive and or motor functioning, and that's represented by this elbow here where there's a downhill decline. This may or may not be causing symptoms. At some point, they are causing symptoms, and the person may not have a dementia syndrome, but they're bothered by cognitive symptoms or hallucinations or some motor features. And the term here is prodromal DLB, meaning that this person's got the early features of evolving DLB. And at some point then the full DLB syndrome happens. Now this is linear. This suggests that most people have a linear course over time. That is true of some. In some people it's really slow. This evolution is very slow over 10, 15 or more years. In some people, it's remarkably fast. From onset of symptoms until death, it's 1 to 2 years. We don't understand why that rate of progression is so variable. And you'll read about the average being somewhere from onset of symptoms in the cognitive realm, onset of symptoms somewhere in the 5 to 10 range, and that may be true, but it's very variable. So this is the natural history schematically in DLB. Currently, what we have available are some medicines that when we treat, either when a person has DLB or in the MCI stage, they can help symptoms, but it's important to emphasize none of the medications have been shown to slow down the rate of progression. Now, these therapies are coming. We don't have these available currently, but the symptoms, the medicines we've been talking about clearly can help symptoms, but they don't change the course. At least the data doesn't suggest that. But we're hoping to have therapies that will alter the course. Better yet, if we can identify people very early in their evolution, if we can start therapies right before a change or very early stage, we have better likelihood of success of slowing down the rate of change, and maybe we can't present MCI or mild cognitive impairment or some of the prodromal features, but try to minimize the evolution to full DLB. Where we really want to be is in a prevention mode. And many groups around the world are studying this, the natural history. Many of the pharmaceutical companies are actively pursuing treatments that get to the root of the problem, affect alpha-synuclein or other aspects of the cascade of the disease process itself. And for example, if we can identify people with REM sleep behavior disorder, this is just one example. There are other early manifestations of DLB, but this is one of the more specific ones. If we could start treatment early, potentially we could either delay the onset and so DLB just would never evolve, or we could prevent the evolution of symptoms altogether. This is a realistic prospect. but this is going to take a lot of work. The scientists and the patients and families to engage in research so we can understand the natural history better, and while we wait for our partners at the basic science level to identify and develop therapies that can impact. So this is coming hopefully within the next 2 to 3 years, at least within the next 5 years. So this is my last slide. So to summarize, and perhaps we can address a lot of questions in this area, as each of you work with the clinicians that you see, it is helpful to try to view symptoms in the cognitive, neuropsychiatric, motor, sleep, and autonomic areas and prioritize. If there was a treatment for this problem, I would rank it number 1, this problem number 2, and this really helps the clinician. And the bottom line is we want to optimize management of these symptoms and the quality of life for patients and their families through education, empowerment, and the use of a number of approaches, medicines and non-medicine approaches. So why don't I stop there, and happy to try to answer any questions.
Okay, thank you, Dr. Beauvais. As you can imagine, we did have questions come in throughout the presentation, and we also had quite a few that were part of the registration process. So I've assembled those in a way where we can take the ones that are about clinical management first, but we also have some questions that are on other topics as well. So if there's time, we can address some of those as well. The first question I'd like to pose, we had several people ask this, and it's surrounding the new medication, the newly FDA-approved medication for psychosis and Parkinson's disease, and that's Nuplazid. Please tell us where the potential is for the use of this drug in DLB.
Okay, good question. So Nuplazid is a novel agent. It works different from the other medications that are used in Parkinson's disease. It's FDA approved for managing hallucinations, delusions associated with Parkinson's disease. Because it's available on the market, physicians can prescribe it, and the data are restricted to Parkinson's disease patients. It would be attractive to consider, since DLB is kind of a cousin to Parkinson's disease, it probably would work in DLB, and it might, but we don't have evidence of that. And DLB patients are a bit more complicated in some of the manifestations. So the bottom line is we don't know the efficacy or the safety or tolerability of Nuplazid yet in DLB. On a practical level, the challenge is the cost. The cost is quite high, and at least right now, at least for folks in the Midwest, which is where I practice, it's very difficult to get coverage through the formulary or through a prescription plan. So there are some appealing aspects of Nuplazid, but there are some challenges in terms of cost and lack of efficacy. But it at least is another option.
Okay, thank you. We had one question come in about the question of when is it time to consider discontinuation of cholinesterase inhibitors as the disease progresses. If somebody is considered to be in the latter stage of the disease, should they remain on the medication? You know, where as a clinician do you draw the line of seeing benefits versus knowing how this may affect people more at the chemical level than the clinical level?
Right, another good question, and we're asked this quite often. And you'll get that there isn't a right or wrong way to proceed. Most patients in the latter stages of the illness, because there just aren't that many neurons making acetylcholine, it's hard for the medicines in that class to act on what little available acetylcholine remains. And so in a significant proportion, you can stop it. It is appropriate, and you don't see any obvious downward turn by stopping it. However, There are some individuals where you do see a significant worsening, either from a cognitive standpoint, functional, hallucinations dramatically get worse. And so we struggle with this. And many clinicians feel that unless there's a really good reason to stop it, they tend to maintain it. And now that all of the cholinesterase inhibitors have generic formulations, costs aren't as much of an issue anymore. But you will, there are varied opinions on this. So my personal tendency is I tend to maintain them in most people.
All right. So we have a few questions that came in on the topic of medical marijuana. Is there any evidence that shows that this can be helpful in a person with LBD?
There isn't any evidence. I'm not aware of any studies that's studying this, as many people know, doing research in at least the classic controlled agents. The FDA does not permit that. All I can say is my N of one. One person with DLB who I followed for many, many years had intractable pain, and his physician did commence him on medical marijuana. He didn't seem to get better, didn't seem to get worse. So it's kind of hard to say from an N of one. So is there logic that it might help? To be honest, it's hard to conceive how that would help, just knowing how complex Lewy body disease is. But without data, it's just hard to say.
Okay, thank you. On that same topic, we do receive regular questions about pain management in LBD for things that could be completely unrelated to it. So I know this isn't part of DLB management, but since pain is such a common thing in older adults from things like arthritis, what's the strategy for pain management if the over-the-counter medicines aren't working?
Yeah, you really have to, I don't mean to dodge the question, but you really have to work with a primary clinician. So there are prescription nonsteroidal anti-inflammatory medications. There are some that have opiate-like properties. There are some of the opiates that do have a role when none of the other medications work. The challenge, though, is if a person's using Coumadin, you have to be careful. There's other drug-drug interactions. So it's very true we want to manage pain, absolutely no question. The general rule is to use non-opiates first, try to exploit those, and if they're just not working, then to consider other forms of medicines. Opiates being one class, there are some in the SNRI category, so they're designed more for depression, but they have some pain modulating properties also. So it's important to work with your local clinician. I wish I could give a simpler answer, but
sometimes there is no obvious single answer we can provide, and we understand that. We have a question that came in regarding monoclonal antibodies. Can you tell us anything about what's in the pipeline right now that may give us some hope for disease-modifying agents?
Yes. Monoclonal antibodies directed against misfolded proteins. This is really one of the biggest waves in the field of age-related neurodegeneration currently. Amyloid monoclonal antibodies directed towards Alzheimer's disease, tau monoclonal antibodies for Alzheimer's disease, as well as the so-called tauopathies, progressive supranuclear palsy, and other similar conditions, and then the alpha-synuclein-oriented immunotherapies for Parkinson's disease and DLB. This is a very active area of research. Several industry organizations have monoclonal antibodies that are in current various levels of investigation. They're relatively early stage still, phase 1, phase 2, but the anticipation is they'll be ready for phase 2B and phase 3 trials over the next 1 to 3 years. Part of the challenge is that many of the companies working in this area, because Parkinson's disease is so much easier to diagnose and the natural progression over time is relatively established, they're focusing more on patients with Parkinson's disease and not as much on DLB, at least as the first population of patients to use these. Now, all of us who are DLB clinicians, we're very, very strongly encouraging these same companies, please, whenever feasible, to embark with clinical trials in DLB populations too. So very active area of research, very exciting to see where this that class is going, but we're still at least a couple years out before DLB patients. But I'm sure as part of the LBDA we'll know this and we'll be able to keep the public aware as those get ready for the clinic.
Thank you. So I have a question here that is tied to, both clinical management and sometimes, perhaps, family management when it comes to the disease and what to expect. We occasionally get this question at LBDA about somebody whose loved one seems to be having a seizure. So are seizures common? Are they part of the DLB clinical picture? And if somebody suspects that a loved one is having a seizure, what should they be doing, and are there treatments for them?
Yes. Seizures are relatively uncommon. I'm not aware of any good data on prevalence or frequency, but probably less than 10% of people with DLB have one or more seizures. They're very upsetting to visualize. If you've never seen a seizure, it's pretty shocking to see, and injuries can happen. So if they happen, we do want to treat it. There are several medications that are effective for treating seizures. Unfortunately, a lot of them do have cognitive side effects. So if it's a single seizure, then many clinicians choose not to add a seizure medicine. If there's more than one grand mal seizure, then it's pretty much declared itself that it would be best to use a medicine. And then which medicine to use, again, it'll depend on other medical issues and other medications to find the best fit.
Okay, thank you. So I'm going to turn to, while we only have about 2 minutes left, I'm going to turn to a couple of questions that were more on the, I would say, miscellaneous category. There was a recent study that was in the news about a link between gut bacteria and Parkinson's disease. And can you, you mentioned earlier in your presentation that the gut, that there are symptoms that link to and prevalence of the Lewy bodies in the gut. And what will this research show us or help us understand more about Lewy body dementia?
It's very interesting. There's been a line of thinking for years now that the alpha-synuclein change begins in the olfactory system in the brain, so around where the nose is, and then in the brainstem along where the nerves that come from the stomach. So one hypothesis is, are we either ingesting or smelling, somehow being exposed to either a virus or something in our diet or some toxin that's going through the nasal passages or into the stomach and therefore into the nervous system. At this point, it's still a hypothesis, and it's been hard to prove or disprove. It's very provocative, but that's about where we are in terms of knowledge. But that's going to be obviously important. If we identify any toxin or infection, obviously avoiding it would be beneficial. But most of those we're not sure which are toxic yet.
Okay, Thank you. We had a number of questions that came in regarding disease progression. And, I think that's understandable from a family perspective is what should they expect? How do they understand where they are within the course of the disease? And you talked a little bit about prognosis. But, are there general stages that kind of identify milestones of where somebody is within the disease course?
Yeah, it's very difficult. This is also an active area of research. There was data just published this past week that on scans, if for example MRI scans does not show much atrophy in the brain, then that person's course may be slower, and perhaps other imaging studies of the brain have some predictive value. The bottom line is we're not good at predicting course or the evolution of symptoms. Everybody wants to know this for very good reasons, but we just don't have that capability yet. So many of the research centers around the country are studying this for obvious reasons, but unfortunately we don't have good answers right now.
Okay, thank you. And one last question before we run out of time. As the disease progresses and people lose the ability to communicate, what can you tell us about speech and how much of this is affected by a change in muscle tone or control versus a cognitive progression? Is it one or the other or both?
Yeah, seeing a speech therapist or speech pathologist is worthwhile, and if the volume of the voice starts to diminish, or if the movement if the movement of the lips and the tongue, I try to imitate that, but probably not very well. We call that a hypokinetic dysarthria. There are techniques to improve on this. Big and Loud program, Lee Silverman voice technique, and the speech pathologists and speech therapists are really the experts in assisting there. When communication is difficult, the question then is it because cognitively just getting the motor programming speech areas to activate, is that the source of the problem, or is cognition okay, but the motor speech element won't work, and could that improve with a dopamine agent, for example? So this is where a speech therapist or speech pathologist can help.
Okay, wonderful. All right, I'd like to thank you once again, Dr. Beauvais, for sharing a very informative and interesting presentation and making time in your busy schedule for us today. And I'd like to thank all of the attendees for joining us. Today's event was sponsored by an unrestricted educational grant from Advanced Sciences. Most LBDA programs are made possible through donations. So if you found this to be a helpful event and you'd like to make a gift, please visit our website, lbda.org, or call our Atlanta office at the number here on your screen. Thank you again for attending our LBD University webinar. We hope you enjoy the rest of your day.
Thanks to everybody.